Hello, everyone. All right. I will give everyone just a moment to wrap up conversations before I welcome you all to our closing session of the day. All right. I'll do the wolf. That's right. How do you know that you have small children? I am Alex Bryden. My pronouns are she, her. It is wonderful to see you all today. I am a white female with long brown hair and sort of a goldish tan suit and super high heels, which I sort of regret. And I am so glad to see you all for what is our sort of super session today. So I encourage everyone, before we even start, to get very comfortable because you will want to stay the entire time. And you can find all the content from the other sessions that are happening concurrently online. I promise it's worth it. So for the first half of this panel, we're gonna hear from kind of two groups of folks today. The first half of this panel is sitting right here on my left. They are colleagues who work either at the Innovation Center or in innovation, and we're going to talk about innovative approaches to health equity and value-based care. The second half of the panel is your opportunity to hear directly from more CMS team members who work on quality measures, clinical standards and quality, and in Center for Medicare around some of the value-based approaches that are really sort of embedding health equity in our Medicare program. And in the fabric of our programs sort of across all of the M's. So it is wonderful to be here, but really, I am not the most important person here at all. I will turn it over to Purva and CMMI and our incredible model participants.
Thank you, Alex. And unlike Alex, I am in flats because that's all I can handle. And I am not the most important person here. I'm immensely grateful to three of our model participants and our model leads who are in the audience for today. I want to just thank the Office of Minority Health at CMS for giving us the time and the space today to bring some of our model participants to you and share some of the work that we're doing. And I also want to thank Samrat Sayum as our Senior Advisor for Health Equity at the Innovation Center for helping craft this panel today. I'm going to go ahead and introduce our panel, give you guys maybe 5 to 7 minutes of just some setup on who we are at the Innovation Center for those of you that are not as familiar with us. I'll talk a little bit about our strategy and our equity work in particular, and then dive into some Q&A, which is where I think why you're all here and where I want to spend most of our time. But on our panel today, we have three model participants and representatives from our models who are going to provide insights on how they are implementing some of our health equity related work in our value-based payment models. I'm really grateful today to be joined by Katy Tapp, who is the Vice President for Clinical Operations at the Commonwealth ACO and is an ACO REACH participant. Misty Chicchirichi, who is the Senior Quality Program Manager for Shenandoah Oncology. They are a participant in our Enhancing Oncology model. And Dr. Unini Odama, who is the Vice President for Medical Affairs, Infection Prevention and Management, and Health Equity for DaVita Kidney Care, who is a participant in our Kidney Care Choices model. I don't know if there we go. So for those of you that are not as familiar with the CMS Innovation Center, we were established in the Affordable Care Act to test new payment and care delivery models that help move us away from a fee-for-service healthcare system to one that pays for value. Value-based care models often provide flexibilities that aren't always otherwise available in fee-for-service payment systems to improve access, to improve quality, and especially to advance health equity and to reduce costs. So you can think of the Innovation Center in some ways as the R&D component of CMS. And some of what I'm going to be describing to you today, specific to our health equity work, will help describe some of the different ways that we're testing health equity related provisions in our models. And if they're successful, then we have hopefully the opportunity to make those changes more broadly in the Medicare and Medicaid programs. Our vision is to build a health system that achieves equitable outcomes through high quality, affordable, person-centered care. And I'll stop on the word equity because that was intentionally part of this renewed vision. We're grounding our vision in the 5 strategic objectives that you see here. The first is driving accountable care so that we have all of our beneficiaries in longitudinal relationships with providers that are responsible for the quality and cost of their care so that everyone has someone quarterbacking their care. Second is advancing health equity. I'm going to hold on that for a second because I'm going to spend a little more time on it on the next slide. Third, our third objective is to support innovation through data, regulatory, and payment flexibilities, and learning supports that enable person-centered, integrated, and more equitable care. The fourth is addressing affordability, for instance, through drug pricing and drug access models. And then finally, partnering to truly achieve system transformation. We can't achieve this vision, and we can't transform the health system into one that's more equitable without partnering with all parts of the health system. Going to focus on our health equity initiative just for a minute. You drill down. These are sort of the 4 prongs of our health equity work that really guide what we're doing. I'll give a little bit of an overview, and that'll tee up some of the questions that I have for the panel. The first is embedding equity into our models, into all aspects of our models. So it's not a siloed part of what we are testing, but a part of everything that we're doing in our models. I'll start a little bit with our health-related social needs work. In all of our models, in all of our new models and redesigned models over the last 2.5 years, we are requiring social screening for health-related social needs, supporting our model participants in making referrals when those health-related social needs are identified, and then helping support their partnerships with community-based organizations. And that work was really informed, and these requirements in our models were really informed by early work that was done at the Innovation Center through our Accountable Health Communities model, which tested whether connecting Medicare and Medicaid beneficiaries to community resources for their health-related social needs actually improves healthcare use and reduces costs. I know that's a question that we think we all kind of have the answer to now, but 7-8 years ago when that model first started, that was a real question for those in the health system. I'm a psychologist by training, so some of this, the connection between health-related social needs and outcomes is intuitive for many of us in that field, but it wasn't always for everyone in healthcare. So the AHC model really catalyzed the systematic identification and addressing social needs, and new findings that are going to be released soon actually emphasize that, and I'll share some of those with you today. Our AHC model is actually showing that patients who are offered navigation for those identified health-related social needs had 4 to 6% fewer ED visits and hospital admissions, which drove Medicare and Medicaid savings. And even though navigation resolved many, but not all of the needs reported by patients, we actually found 40% reported that at least one of their social needs was resolved, and that 28% of beneficiaries reported that all of their needs were resolved. And we're seeing that number going up year over year as our evaluation results come out on that model. Second, under that first bucket, not only are we, have a emphasis on addressing health-related social needs, we're also testing payment. We know that oftentimes providers who are caring for underserved beneficiaries, they need additional resources to be able to meet those beneficiaries' needs. We are testing some of the first of their kind payment adjustments that are based on social risk to help healthcare providers in underserved communities and to attract new providers and increase access into those communities. And last, we are also developing tools to help our model participants identify disparities and needs in the communities that they're serving through health equity plans. That's also one of the things we have in many of our models now. And it's really an organizing tool to help support the identification, as I said, of disparities, to support the identification of interventions to then address those disparities, and then supporting ways to measure progress over time. The second area that you see here is increasing the diversity of beneficiaries that are served by our models. Looking back, before our strategy was released in 2021, we saw that our models were often not reaching, our value-based care models were not reaching a representative group of our beneficiaries. And so to reach a more diverse set of beneficiaries, we have to bring a more diverse set of healthcare providers into our models. And this is a critical focus of a lot of the work that we're doing. So we have, I talked a little bit about payment adjustments. When we think about value-based care models, oftentimes people think about financial risk. And so we know that is different for safety net providers. And so in some cases, we have model options that have no risk or that have glide paths to lower levels of risk than maybe for other healthcare organizations. Many of our models are now also including upfront infrastructure payments. We know that to support team-based care, to have the data analytics and the IT infrastructure to undertake value-based care, you need to make an investment. And so in many of our models, we're also providing upfront infrastructure payments. So really thinking through what are the different supports that we can offer in our models to bring these providers in. I'm going to skip to our fourth area of focus really fast because it actually informs evaluation. But we know that we need good data. We need good data across all of our the beneficiaries that we're serving to monitor the impacts of the things that we are testing, and then to understand if we're closing disparities over time. So all of our models are also collecting self-reported demographic data collection, and we're hoping that really helps us with what you see there as the third prong of our initiative, which is evaluation. That we really want to, at the beginning of our journey and designing a model, launching a model, really be thinking thoughtfully about the key questions, the key things that we're testing from an equity perspective, and then making sure that we're monitoring and understanding what the impact of all of this work is. So for those of you that are interested, for each of our objectives, our health equity objective, for each of our objectives, but this is our health equity objective in particular, we have public metrics that we're measuring our progress against, and we'll be releasing some public information in 2025 about our progress. I'm going to talk really briefly about the three models that we have represented here, and then start and kick off the panel. The first is our ACO REACH model. The ACO REACH model encourages healthcare providers, including primary care and specialty care, doctors, hospitals, and others, to come together to form accountable care organizations. Patients in a REACH ACO often get help navigating the health system and managing their health conditions. They may have greater access to enhanced benefits such as telehealth visits, home care after leaving the hospital, and even help with copays. The model also requires all REACH ACOs to have a robust plan for meeting the needs of their patients in underserved communities and to make measurable changes to address health disparities. And I will say ACO REACH was the first model that we redesigned with equity in mind and has really been leading the way in many ways. And Katy will give us the perspective of somebody that's in year 2 of this journey in ACO REACH. The next model is our Enhancing Oncology model, which aims to improve coordination across a cancer patient's healthcare providers and supports personalized services to help individuals navigate and manage their cancer care. EOM participants take into consideration their patients' preferences and goals for their treatment, their health-related social needs, as well as psychosocial health needs. EOM also provides additional support to participants who treat underserved or lower-income patients, specifically those who are dual eligible. And the additional supports really aim to lead to improved access, treatment, and outcomes for these beneficiaries. And EOM is wrapping up its first year into this journey, so you'll get a little bit of a different look from Katy and Misty about their experiences. And then last but not least is our model that's the newest in this journey is our Kidney Care Choices model. In KCC, we have groups of nephrologists and other providers and practices come together to take responsibility for patients who have late-stage chronic kidney disease or end-stage renal disease or a kidney transplant. They offer coordinated and seamless care, including dialysis, transplant, and if appropriate, even end-of-life care. The model really aims to reduce the number of patients that are developing kidney failure, to have fewer patients receive dialysis in dialysis centers, and to increase the number of kidney transplants so patients can live longer, healthier lives. So with that, I'm going to invite each of our panelists to introduce themselves, their organization. Why don't we start with Dr. Odama?
Well, thank you so much. Thank you very much for the invitation. Really appreciate the opportunity to be here. My name is Unini Odama. I'm a nephrologist, and currently I work for DaVita. DaVita is one of the largest kidney care organizations, serving over 200,000 persons. And I am VP of Medical Affairs there and the physician lead for health equity, infection prevention, and management. In terms of our health equity model, as an organization, we call ourselves a village. But as the village, we really focus on health equity using a strategy. We started this journey about over 3 years ago. And we have our strategy, which is based on 3 different pillars, which I hope we'll be able to have time to talk about later. And the first is really building the foundation. The second is addressing the disparities and then spreading ripples, which is part of what we're doing here today. So thank you so much.
Thanks for being here. Katy?
Hi, everyone. I'm Katy Tapp. I'm the VP of Clinical Operations for Commonwealth ACO and a social worker by training. Commonwealth is a REACH ACO. As was mentioned, this is our second year in the REACH model. We were previously in the Medicare Shared Savings Program for about a decade in the value-based world before transitioning to the REACH model. We're located in Arizona, with most of our practices being in the Phoenix metropolitan area, but have expanded our footprint even more this year to some of the outlying areas in Arizona, some more remote areas, as well as Texas. We are independently owned by a group of independently operating primary care physicians, and our goal as an ACO is to help them remain practicing independently in a very competitive market in the Phoenix area.
Misty?
Hi, my name's Misty Chicchirichi. I'm an RN by trade. I'm the quality program lead at Shenandoah Oncology in Winchester, Virginia. We have 8 physicians, 9 nurse practitioners, and a social worker that provides counseling. My role as the quality program lead is to help transform the practice with some of our value-based care programs that we're participating in. The EOM has a very strong focus on social determinants of health and health equity. And so we utilize a tool called the NCCN Distress Thermometer that helps us find out if they're having financial issues, housing, utility, transportation, or food insecurity.
Great, thank you. I'm going to dive right in because we have 27 minutes before our colleagues have to come on. So I want to cover as much ground as we can. I'm going to start with Dr. Odama for the first question. Can you talk a little bit about the opportunities that have emerged for you all to address health equity and disparities in the kidney care choices model that you're participating in?
Yeah, thanks. First of all, when we talk about value-based care, I always step back and ask the question, value for whom? All right. So we serve, as you know, very vulnerable patients, and persons who are living with kidney disease. So it's always good to step back from just the phrase and ask yourself, value for whom, and what outcomes are we seeking for, and who do they benefit? So that's the very first thing. And then thinking about value-based care, the opportunities that arise really are to see value as health. And we're talking about health in general, holistically, and not just the absence of disease. Because our persons who are suffering from kidney disease, that's not what makes them, that's not what defines them. There's a whole part of them that we need to really focus on. So the first opportunity is to see value as health. The second opportunity is to really see value as social care, because if we're thinking about health and the optimal value is absence of disease, then we of course have to think about the things that lead to kidney disease. And we know that hypertension and diabetes are the commonest causes of kidney disease. And so value-based care gives us the opportunity to really think about value as social care. The other thing that we need to really start to come back to is value as autonomy, patient dignity, because we throw out a lot of things that we think are good for the patient or for the person, but then you have to sit back and ask, do all of our patients want to be on immunosuppressive agents forever when they get a transplant? Do all of them really want to be at home? How about those who see the dialysis unit as a place for socialization? So before we start to really define value, it's very important that we actually sit and listen to our patients. So I think value-based care and the model that we have give us that opportunity to really be humble. Okay. And to really be accountable, find out what is within our purview, and how do we begin to collaborate and cross lanes. Historically, in the renal world or taking care of kidney disease, we normally just operate in silos. But the value-based care model gives us the opportunity to really have these multidisciplinary cross-lane interactions that help us to bring the true value to our patients. And then, of course, to remain person-centric, as opposed to just chasing a metric, because the problem is that once we chase a metric, that metric becomes what leads us instead of the value to the patient. So we're very pleased to have this opportunity with value-based care to do these things.
Thank you. I'm really glad you unpacked that term. I was like taking notes because you use the word dignity, you use the word humble or humility, and person-centered, and being person-centric. And hopefully that's what the testing of some of these approaches is unlocking for all of us. I'm going to turn to Misty next. You already in your opening remarks talked a little bit about how you're really focusing on SDOH and health-related social needs and some of the tools you're using. So can you talk a little bit about how Shenandoah Oncology is addressing social determinants of health in everyday practice?
When we did the application for the Enhancing Oncology model, we really saw there was going to be a strong need for us to be able to address the social determinants of health. We had one social worker, and we really wanted her to be able to focus on those emotional. So we looked at patient navigators, lay patient navigators. They are not nurses. One's a medical assistant, and one has just been trained working with me over the years. And so they really focus on the NCCN portion that talks about finances, housing, transportation, food insecurity, things of those nature. We also knew that we live in an area that 7 of our 13 counties are a high utilization of SNAP benefits or food stamps. And then 6 of those counties are also considered food deserts. So we really needed to be able to reach our patients. Having good food in them helps them have better outcomes with chemotherapy, helps prevent hospitalizations, improves their quality of life. So we are a part of the U.S. Oncology Network, and we are very blessed to be able to have what's called Find Help. It used to be Aunt Bertha, and now it's called Find Help. So we can type in a patient's zip code and be able to find if we want a food bank or if we want to find help with transportation or utilities. So that's been huge for us because of how rural a lot of our counties are.
Thank you. Dr. Odama, I was going to ask you a similar question about how you're doing this in your practices in terms of addressing some of the social determinants of health.
Yeah, thanks for that question. And it starts by, again, knowing our patients and our person population. And we use the strategy that I talked about, is to build the foundation. And how did we do that? We decided that we needed to really look at national data to see where the disparities were, and then to look inwards at our data to see where the gaps were. And from that, we were able to find out that we had huge disparities in home dialysis and in transplantation. But the most important question is why? Well, we could not answer that question ourselves, so we decided to listen. And we went on tours around the country, asking our patients qualitative data, really sitting down with our patients and their support system, asking them what the barriers were, especially to home dialysis. And we heard very, very, very important information we got from them. For example, that they really, really valued their physicians, that there was a difference between our African American and our Mexican American patients in terms of whether they trust and just trust, or they need to trust and verify. They also told us that they have a difficulty linking the risk factors of kidney disease with kidney disease. They knew that they had hypertension, diabetes, but they didn't link that with kidney disease. So we heard all of these things. We also decided to really listen to our dual eligible patients. And we found out that yes, they may have transportation help, but it's nuanced. They spend 2 hours going to dialysis, 2 hours coming back. Is that true value? They talked about food. We give them all these recommendations about the kind of food they should eat, but it's not culturally palatable to them. So we started to really, really get below the surface of just, determinants of health. And we found out they were very nuanced in our patients. Then we moved over to transplant, and we said, what are the barriers in our patients? We found, and they told us, that they really need hand-holding all the way from mile 0 to mile 26. And without that, it's very, very difficult. And using our pilot, we were able to understand that we can actually get people interested in living kidney donation, move them from inactive wait lists to active wait lists, and even get them transplanted. So we heard all of these things, and then we went to the second step, which is to address the disparities. We started to think about how can we re-engineer our education so that our patients can really begin to understand what kidney disease is. And then we decided no better way than to partner with communities. And now we partner with the National Y, and we're in those communities. We started out in Baton Rouge, had a very good opportunity there to address that linkage of care and to also address the link between the risk factors and kidney disease. So we're raising awareness for kidney disease. We are making sure that education is done and it's linking the risk factors. We're screening for early CKD, and then we're linking them to community resources. So some of these things have been brought to the forefront by our value-based model, but we're making sure that we're doing this for all of our patients. And as we continue to press in with our prepare tools, we hope that we'll be able to find more nuances to be able to keep on addressing and prioritizing the determinants of health. We also have other opportunities that value-based care has afforded us. For example, we collaborate with the Food and Medicine to prepare a medically tailored food for our patients that have both chronic kidney disease and end-stage renal disease, and also some transportation pilots to see what really works. Because again, people that have kidney disease, they're nuanced, always have to dig below the surface to get to the root cause so that we can truly add value to their lives. So that's how we address it.
Thank you. We talk a lot about across CMS screening for health-related social needs, referral, but both of you brought it to life and really personalize it in terms of the communities and the patients that you're serving. Katy, I'm going to turn to you next. Could you share your experiences with, including challenges is okay too, with implementing the health equity data collection and reporting requirements within your ACO? I talked a little bit about why that's such a key part of the equity initiative and us having accurate data, but I think you've been through a full year of it now, so I'd love to hear your experiences.
Yes, happy to share those experiences and chat with anyone else who might be going through that process here today to compare notes. Last year was our first year in REACH and our first year reporting our health equity data. We started with demographic data, collecting that information on each and every one of our patients as best we could to report back to CMS. And so that included race, ethnicity, and preferred language for each of our beneficiaries. But we received an incentive from CMS to support those efforts. And that was part of the calculation into the bottom line, essentially, for the year for us. And so that incentive is what truly motivated us to tackle that data reporting element. This year, we are working to include SDOH information into the health equity data reporting requirement per CMS for 2024 data. And so collecting that information, if anyone was in the data session earlier today, some of the challenges with collecting that information were discussed, and it is tricky to collect it and then aggregate it and report it back to CMS. We are happy that there's the G code for billing that at the practice level this year. That's been tremendously helpful for our providers. The guidance for the evidence-based screeners that are appropriate to use for that, we've been able to work the North Carolina assessment into our annual wellness visit packet for all of our primary care physicians, so that at the time of the annual wellness visit for all of our patients, they are completing in the office the SDOH needs assessments alongside the medical assistant or with the providers in the office. We're hoping that that is a safe and trusted place for them to discuss all of the elements elements of that assessment. And as an ACO, we're taking on the responsibility of making sure our practices have the resources and the knowledge of the community support that's available to address any needs that are identified in collecting that SDOH information. Our challenge then becomes making sure that we have a way to aggregate it with all of the different EHRs that our practices use. They're on everything under the sun. So trying to collect that information and report it back is very challenging, but we understand why it's being collected. And we hope to get to a point where we can actually look at our numbers as an ACO and figure out what the health-related social needs of our beneficiaries truly are, so we know where to focus our efforts as an ACO to support our underserved communities.
The word that's coming to mind is journey. It's definitely a journey, and you started
Definitely,
it.
yes.
Misty, same question for you. I'd be really interested. You're almost a year into the Enhancing Oncology model, and I don't know if you could share your experience a little bit with some of the health equity data reporting.
Sure. So far, we haven't had to report it. Up until about fall of 2023, we had just a paper tool for the NCCN distress thermometer. Then McKesson US Oncology developed it so that way it could be input into the medical record. So now when we receive the completed screen, our patient navigators input that data, whatever they answered positive or concerns about, into G2, and we can develop reports, kind of look at, okay, we've been focused on food insecurity. What's the big concern now? It looks like transportation is going to be our next hurdle that we're going to want to try to tackle and be creative with. So that's how we've used our data. We also have to collect those other, it's passing me up now, but like sexual orientation, language, those sorts of things. We have to collect that as well and submit that to CMS too, but we haven't had to do it yet.
Thank you. Katy, I'm going to turn to you for the next question. I talked a little bit at the beginning about how we're testing different ways of socially risk adjusting payments. And again, ACO REACH was the first one where we adjusted the benchmark itself. How has that health equity benchmark adjustment impacted your ACO? How has it allowed you, what has it allowed you to do?
Sure. So last year, again, being our first year in the REACH model, we were excited to join the REACH program because we knew that about 20% of our beneficiaries lived in a very rural area in Northeast Arizona, one of the most rural counties in Arizona. So we felt pretty confident that that health equity benchmark adjustment would work in our favor to be able to have the additional resources to serve those patients and support them. When we got the calculation, we found out we actually had about a 4% adjustment in the opposite direction for 2023. So that was a bit tricky, but for 2024, we've actually gone the other way, and we do have a lift in our health equity benchmark for 2024. So we're excited to see that. I wish I could say after 2023, we hit the pavement in rural communities to recruit practices to join the ACO. For 2024, that would be a bit of an oversimplification of what actually happened. But given the market in the Phoenix area, we did naturally expand to more rural parts of Arizona. Our practices within the ACO added additional offices in more rural parts of Arizona for the same reason. And so our growth and our footprint ended up going into those more rural areas naturally. And that health equity benchmark is what gave us the confidence to really take those practices on, knowing that we would get that adjustment to make the accommodations we needed to make for areas in those rural communities that do often have that high spend, just a result of not having many options outside of the inpatient setting in those areas.
Thank you, Katy. Misty, I'm going to come to you for the next question around our health equity plans. I talked a little bit about those hopefully being organizing tools for our participants. Another place where we're doing a lot of work, a lot of learning from these early models, and then thinking about how we potentially standardize our approaches more, reduce the lift for our model participants. But can you discuss your experience a little bit in the developing the health equity plans?
For the EOM, the first health equity plan that we had to do was in the fall of 2023, and it was an optional opportunity. And I will admit that I felt like a dog chasing my tail, because I was like, what's the inequity? Everybody says we have a lot of this or a lot of that. So I took a look at our oncology care model patients from 2022 and their NCCN distress thermometer answers, and just hand tally pain, transportation, food insecurity, and came up with food insecurity was the biggest concern for our 2022 patients. So then I started digging into some websites that CMS provided through like the USDA, and was able to find some of those stats that I mentioned about food deserts and SNAP benefits, and just really felt like this is where we needed to go as a practice. So we submitted our first, the optional one in the fall, received really great feedback from Medicare, but then we're also with US Oncology. So then when the spring health equity plan, which was required, needed to come out, we were able to collaborate with practices across the US that were also in the EOM and be able to hear what they were focused on. So like if there was a practice out in Arizona that also had food insecurity, I was able to hear their ideas and how they were going to meet those needs. And maybe transportation wasn't a big deal, but I could give some of our ideas that other practices may have not thought of. So it's really great to have that village of our network to be able to share that, but then to write that health equity plan and be able to put it into play and be able to use it throughout our practice and for our patients really means a lot.
Thank you. Dr. Odama, can you talk a little bit about how you're thinking about approaching some of the health equity plans? I know in KCC it's not quite live yet, so
Yes.
get a different perspective maybe.
Exactly, a different perspective. But in our situation, we've had a 3-year runway. So before we knew that CMS or CMMI would put these requirements in place, we had started to build a foundation. And how we started to build a foundation also included making sure that organizationally, internally, we were aware of what health equity was, and we were aware of where our gaps were. And we have an organizational health equity dashboard that we can use to look at where the disparities are. We actually went on a health equity tour to all our KCE entities with our nephrology practices, and regionally providing them with the information and showing them where the disparities were long before there was a requirement. And so really just raising awareness, making people more sensitized to outcomes and where disparities are. And then we also learned that we had to do a lot of training. So we have health equity training modules for not just our nephrologists, but also non-clinical staff in our organization. Just again, because we know that in order to create a plan that is sustainable and works, we do need buy-in from everybody. And so after all of that, we also did cultural humility training to be able to ask questions. I heard you talk about asking those questions. We are finding out that, again, talking about value, it has to be value for not just the patients, but the teammates, the healthcare team. And they're very uncomfortable asking those very sensitive questions that we're being asked to, and then the other thing that we're finding out is capacity, where the model asks to really, get information about PAMS and PHQ-9s and SDOH and so many things. And the capacity is really, really being stretched in terms of our teammates and this discomfort level, asking those very sensitive questions. So we had to take a step back, at the beginning to say, okay, well, let's do some training about how to ask sensitive questions and culturally sensitive questions. And so we're doing that now. So we did that. that. And then looking at we have a health equity team at DaVita, and so we initiate and the teams, and regionally we look at where the disparities are with with our facility leaders, and really direct them to be able to focus on where their own local disparities are, because these plans truly have to be local. They can't just be organizational, and there has to be local leadership buy-in. So by doing all this, building the foundation, they're getting to the point where they're more comfortable with it. And of course, the health equity team is there to guide, to train, and to make sure that, things are going well. So that's where we are right now, at that beginning phase, but with a long runway.
Yeah.
Yes.
Katy, I don't know if you have anything you want to add here, having been a little bit further along, and I think going through cycle 2 on some of these plans or updating them.
Yes, I'd love to speak to our health equity plan at Commonwealth. We put together our health equity plan last year and just submitted updates for our health equity plan for 2024 to give a progress report on how it went last year. For our health equity plan that we put together last year, we wanted to use the data available to us through our claims data, through U.S. Census data, through the county health rankings tool to figure out where our underserved communities lied within our beneficiaries. And we quickly knew that that 20% of our beneficiaries who lived in Navajo County would be that outlying community. And the data supported that. In a nutshell, the average life expectancy in Navajo County is 8 years shorter than that of Maricopa County, where the rest of our practices were. And so we knew we wanted to focus on our beneficiaries in that northeast section of Arizona and Navajo County. We worked with the clinical staff in our practice up there to get a sense of what they were finding, the issues that they were encountering with patients, and where the additional support needed to focus on. And they quickly identified the diabetic patients within their practice as a really high area of need. So simultaneously, we looked at the conversations we were having with an ophthalmology partner in the Phoenix area. And they had resources of 3 fundus cameras that were available to us that they wanted to put in our practices to collect images, retinal images, and be able to do a remote review of those images to complete the requirements for DREs for our diabetic patients. So immediately we put one of those cameras in our office in Navajo County so that our office could collect those retinal images in their practice. We went up and did a training with all of the medical staff there, all the MAs, so that they knew how to take the images, upload them into the secure portal for review by our ophthalmologist down in Phoenix, and then within 48 hours, get those results back to the patients. So our hope was to start small, start with a very targeted population before we knew what that benchmark adjustment would really look like, use the resources available to us. And we ended up seeing a 37% increase in DRE completion in Navajo County for our beneficiaries. So we were hoping to expand on that moving forward to get resources for more diabetic supplies, expand beyond the diabetic community within that population, dig into nephrology a little bit, see what support we can put in place there for those patients. We know dialysis centers are really hard to come by up there, so we're looking to expand those resources further, but feel like we're off to a great start there.
We're excited to see what you do and to learn from what you do. So we have like 2 minutes left. And for all of you that skip the lightning rounds upstairs, we'll have one right here. We'll start with Misty and just come down the line. But really quick, if you had to share one opportunity that you think you see through the focus on health equity and EOM, and one challenge, and if each of you could just share an opportunity and challenge to wrap up, that'd be great.
I think our biggest challenge, I'll start with the challenge first, is while we have a lot of great resources, the challenge is guiding the patients to those resources. So we're able to provide them where food banks are, but having them utilize it is hard. It's a little embarrassing. So we created a food pantry within our cancer center where they can come upstairs privately and get dry goods. We also have partnered with Highland Food Pantry, and they're going to start doing deliveries while the patients are receiving treatment. So that way they can take those dry goods home. I would say the thing I'm most excited about is the fact that CMS is now allowing, once a lay navigator is certified, to bill for their services. And while that's not a whole lot of financial, there are times where my navigators are spending about an hour and a half just setting up transportation because radiation's 5 days a week, chemotherapy once a week, going to the surgeon, coming in to see the oncologist, and that can take a lot of time. So being able to bill for those services then will be able to give me the opportunity to go to our leadership and say, hey, we're generating this revenue. We would like to be able to hire more navigators. That way we can reach out to more patients.
Thank you, Katy.
So I'd say one of our most exciting areas of opportunity are some of the support that we are getting from CMS to promote health equity. The fact that there is a REACH ACO model to target health equity, the additional care management codes that we see continuously coming out year after year to expand upon TCM, CCM, PCM, all of those different areas. We have a very robust care management team, a wonderful team of nurses, and we're excited to build on that program and really make sure that we can use that remote support for all of our patients across the state. And those additional revenue sources for our providers being independent is really important too. We're seeing some fall into more of the concierge model, which is really concerning for health equity. That's the antithesis of health equity. So we want our providers to avoid having to resort to concierge medicine. Probably the biggest challenge for us is figuring out the best ways to do some of that data collection and having the software needed to marry the claims data with the data we're receiving from our practices and just having everything in one place so that we can be as efficient as possible. That's always a challenge for us.
Dr. Odama?
Right, thank you. And I was just, thinking about it, even as I sat here listening to everyone, and what are the biggest challenges for us in terms of taking care of people with kidney disease? It's such a complicated disease that the challenge would be really getting to the target root cause and being able to focus on the right thing that would make sure that we're moving towards equity. And the other issue, of course, is as we live in a world of, just increase in technology, lots of data. How do we prevent ourselves from being metric driven and simultaneously really, really focusing on the person? It's so important that we get back to the basics of care, which starts from the person. So those are two big challenges. And of course, then once we find the solution, who funds it and who remains accountable so that it's sustainable and embedded? Okay, so that goes with it. But what I'm excited for is the ability to really have collaborations and come out of the silos that we've been in traditionally and really work across lanes, big pharma and policymakers and large dialysis organizations and academic medical centers and all of us in the same room for the same purpose. This is really exciting, a great opportunity. And of course, to be able to focus on those structures and systems that have continually created the environment for people to continue to fall off the cliff, meaning end-stage kidney disease. And I'm really excited that we have the opportunity to target these determinants of health. And the truth is, we will not be satisfied until there's health justice, in particular kidney health justice. Our team is laser focused on that, and we'll continue to push forward. We hope that we'll be able to do it continually with CMS and CMMI.
Well, I don't think I can top that. So I'm just going to say I'm really honored that I could be here today and have this discussion with you all. It's an honor to hear about the work that you're doing on the ground. I know that it's energizing for me when we're talking about things at CMS, actually see how some of this work is happening on the ground. And I'm also proud to say that we did not shy away from talking about challenges either and the work that we still have to do together. So thank you.
All right, we're doing a panelist swap, but please don't leave because as I bring folks up to the stage, I'll just do a little bit of a segue. So we just heard some incredible dynamic things that that some of our folks in the field, and I'm sure you all are doing, to identify needs and assess where there are gaps, and then just do incredibly innovative sort of connecting activities to make sure that people who are coming into care settings are getting the services and supports that they need to live a better, healthier life. Now, I think actually the panelists sort of did a really great tee up. They talked about some things going on in the Medicare program that are really exciting and helping to enable that sort of dynamic innovation. I will tell you, we are about to have 4 panelists. They're going to talk lightning fast, which is a direct contrast to the speed at which CMS is able to change our programs. So the work that they're doing, that's an easy joke, but the work that they're doing here represents weeks, months, hours, and years of work to pull health equity in and embed it into the sort of the bedrock of our programs, our quality measurement and Medicare fee for service, which are sort of the base of everything we do here at the agency, and also the slowest moving. So it will be epic to hear the work that's happened in the last sort of couple of years to really ground equity. So you're going to hear from 4 people: Cindy Massuda, Chris Palmer, Lucy Bertocci, Maya Peterson. They're going to talk about some innovations in post-acute care, some innovations in Medicare fee for service, some of the things that our panelists actually talked about, and some of the new codes and ways that we're addressing health-related social needs as we drive our programs forward. I will not belabor this any longer. With that, I will turn it over to Cindy, and you're going to hear them all go kind of lightning fast so we get you out on time. And hopefully there will be time for Q&As. If there aren't, you know where to find us, first name, last name at cms.hhs.gov. We are easily findable. All right, with that, Cindy. Oh, you'd like to advance your own slides? Yes. No. Thank you all.
Just this one?
I think so.
Okay.
I'll tell you.
So good afternoon, and thank you for inviting us today. I'm Cindy Massuda. I'm head of the Health Equity for Post-Acute Care for Quality Measures and Value-Based Purchasing. And for our presentation, myself and Chris, we're going to be talking about the exciting work we've been doing on health equity related to preliminary results for the screen positive for health-related social needs and national summary statistics for the 2023 health equity confidential feedback reports related to 2 of our quality measures and addressing health equity in skilled nursing facilities and value-based purchasing. So starting with the screen positive. So we have in our post-acute care programs, we've been collecting 4 health-related social needs: the need for interpreter services, transportation, health literacy, and social isolation. And these are being collected in our programs in home health, in hospice, home health, IRF, inpatient rehab facilities, long-term care hospitals, and in the SNF, the skilled nursing facilities. And they're collected on our assessments, and they're standardized across all 4 programs. I'm not sure why I got small. But anyway, so what we were doing right now, and this is our cutting edge work. I mean, when I say cutting edge, this is our hot off the presses work. We are now taking those data elements and we have turned them into health related social needs indicator by trying to screen positive, by taking the number of admitted patients, who reported at least one health-related social needs and dividing it by the total number of health-related social need of all patients, so that we can see who's screening positive. So to begin to start looking at that data, just to orient yourself, we have for home health, we have this is looking at the need for an interpreter services. And the top here, where it says, do you need or want an interpreter to communicate with a doctor or healthcare staff? Those are the standard questions. And I'm going to focus on this and then move to get through the topics because we have very little time to one of our later slides. But just to focus you as you go through them, we have 6,628,489 home health patients. And then of those, 251,770 screened positive, which equaled 3.8% in home health. In IRF, for their numbers, it was 2.54%. And in long-term care hospitals, it's 3.2%. I just want to caveat, we also collect this work in SNF, but because this data that we're working with is from October of 2022 to September 30th of 2023, it is too early to have the SNF. We're too early at this time to have the SNF data. So it'll be available shortly, but it's not available at this time. So that's why we're focusing on the other three areas. But to give you a sense, we stratified the data. And this is the kind of an important message. We stratified the data by age, gender, race, and ethnicity, and for the other provider types, also by payer type. And what you're seeing is, even though we showed relatively low numbers for the need for an interpreter, you can see that when you stratify the data by these different categories, that we're showing very high need for Hispanic patients for an interpreter relative to the non-Hispanic Black, non-Hispanic White. And that and you can see similar numbers for both gender and age. And then I'm going to start scrolling through quicker to get to, because of the timing. When we do this for all our other, you can see the data across the different health-related social needs. And I'm going to get up to our slide 24. Because, so when we get to looking at this data across through all health-related social needs, you can now see that for health literacy, we have 45% of the patients that's our highest area for health-related social needs, is in health literacy. It's 45, almost 46% in home health, almost 28% in IRFs, and almost 30% in long-term care hospitals. And you can see the second highest is social isolation, where you can see those numbers, 15.57 in home health, almost 10% in IRFs, and about 12% in long-term care hospitals. So you can get an appreciation for how these health-related social needs. But also when we do unique testing for at least having one of the four health-related social needs, you can see how high these percentages become, almost 55% in home health, 36% in IRFs, and almost 40% in LTECs. And so the implications from this work is showing that we really do the importance of stratifying the data, and that screening positive for health-related social need is an important step toward expanding the collection and reporting and analyzing of our standardized equity-related data across the post-acute care settings. And health literacy, as I said, was our most prevalent, followed by social isolation, which is showing a need for future research in that area, which is showing next steps that we're headed toward. And this work just highlights the importance of stratifying this health-related social needs data across patient populations. I'm then going to move on. Other work that we've done has been, back in October of 2023, released confidential feedback reports, and we released them on 2 of our quality measures. I was prior just talking about indicators. I'm now talking about actual quality measures. This is discharge to community and Medicare spending per beneficiary. These are claims-based measures that we collected in home health, inpatient rehab facilities, IRFs, LTECs, and SNFs. And we stratified this data along Medicare, dual eligible, and also between race and ethnicity. And some of the highlights of this work are being released in an upcoming report, and it's showing the statistically significant aspects of looking at the data. We've looked at it both across looking at the data across. So looking at the facility itself and comparing it nationally, that's what this is looking at. And the orange, just to orient all of us so we're on the same page, the orange are what's statistically significant of showing worst care. The gray bar is showing that where you have similar care, and the blue is better care. And what you're seeing is that for the most part, with the exception of IRFs for non-whites, that the duals have performing worse than nationally in the different settings, and the non-whites are also performing worse in all settings other than for the inpatient rehab facility. And in particular, you're seeing that the skilled nursing facility has for the duals has 37.29% of their patients not being discharged back into the community, performing worse. I'll just breeze through. We did a similar for within patients, comparing it like LTEC patients within a facility for duals to their non-dual patients. And then we have that. And then we also keep going. We also have looked at this through this report and looking at the data stratified. This is, as an example, a highlight, the duals and non-duals for discharge to community rates. And what you're looking at, the thick line or the continuous line are duals, and the dashed lines are the non-duals. And what you're seeing is on the vertical axis, obviously, ideally, you'd want to see 100% of patients discharged back into the community. So the higher up the axis, the better discharge to community. And going across, that's an increase in the proportion of dual patients. So that's more dual patients. And what you're seeing is, looking at the gray line for the LTECs, you're seeing that as you increase the number of duals, it's going down slightly. It's more pronounced for our SNFs, and our SNFs is actually where we're seeing the biggest distinction between the populations, between the duals and non-duals. And the only slightly positive area is where you're seeing the slight up on the blue with the home health. We've also, another way of looking at this data is through heat mapping. And this is looking at it through looking at absolute differences between it. And in all regions, what you're seeing is that there's worse for duals than non-duals, with the largest difference happening in the South Atlantic region, the dark blue. So the lighter blue, these are looking at absolute differences between duals and non-duals for discharge to community, as what we're highlighting here. So the light blue in the mountain area and Northeast area have the least difference, but the biggest difference, as you can see, is that dark blue in the South Atlantic region. And so this is an ability for us to be looking at data in multiple different ways to get more of an understanding and an appreciation for health equity issues that we need to be focused on and working with our providers. And with that, I'm going to turn it over to my colleague, Chris. Thank you. Yes.
Good afternoon, everyone. I'm Chris Palmer, the SNF VBP Program Coordinator at CMS, and I'm excited today to discuss with you how we are looking to address health equity as part of our SNF VBP program. For a quick reminder, for those who may be unaware, the SNF VBP program was established in 2014 and initially consisted of only a single quality measure, our SNF 30-day all-cause readmission measure. In 2021, under the CAA, it was expanded with up to 9 additional measures, bringing it to a potential 10 measures, of which we currently have 8 measures in the program. In 2022, we decided to start the journey to see how we could help incorporate health equity into the program itself and ensure high quality care to SNFs across the country. So, how is the current SNF VBP program set up? It is a quality program in which SNFs can earn the higher of either 10 points for achievement on how they have done on our quality measures against in comparison to other SNFs, or 9 points for improvement on how they've done and improved their own performance for each of the 8 measures we currently have in the program. The points are added up and normalized to a score that ranges from 0 to 100, and then we transform the points into a payment adjustment where higher scores result in the SNFs getting higher payments than if the SNF VBP did not exist, or lower scores result in lower payments. It's important to note that the original design does not attempt to address any concerns about the care received by the underserved population, which was something we wanted to address. Oh, kept in the wrong button there. So we initially then decided to try to determine how we could address health equity in the SNF VBP program. And we started with some overarching questions. Some of the things we considered: does the potential approach we could utilize incentivize SNFs to address health equity? Does it provide large enough incentives to change their performance? Is it a operationally feasible approach? Would it reward poor performing SNFs? Would it be perceived by interested parties and the SNFs themselves? Does it undermine the main incentive structure of the VBP program? And is the incentive structure the best way to target the underserved population? There we go. So, our health equity journey commenced in the summer of 2022 when CMS identified 22 potential approaches to incorporate health equity into the SNF VBP. In the fall of 2022, we debated potential criteria we could use to narrow down our approaches. And then, towards the end of 2022, we eliminated certain approaches based on our potential criteria and ones that we considered were operationally feasible to incorporate into the program. We then also conducted additional analyses to understand the impact of our proposed approach. Last year, in April of 2023, we proposed and published the health equity adjustment and a health equity RFI as part of the FY 2024 SNF PPS proposed rule. And then last summer, we then finalized our health equity adjustment and have begun analysis on additional approaches we could potentially intake. On this slide, we see the 22 unique health equity approaches we considered back in 2022. To speed things up, these were based on 6 different categories. The potential approaches included bonus points, new measures that would be based solely on health equity, potential payment adjustments to the program, performance standards adjustments, risk adjustments, and potentially stratified. Not to spoil anything, but we eventually went with the bonus point approach, as you will soon find out. So, as I mentioned earlier, we were able to identify, propose, and finalize a health equity adjustment that we could be applied immediately into the SNF VBP program. As we discussed earlier, sometimes CMS moves at kind of glacial pace. So we felt it was important to try to implement an HEA as soon as we could. And similarly, at the same time last year, we released an RFI about next steps to determine continued enhancements to the HEA, which we are working on currently. So the HEA we established into the SNF VBP program aims to reward excellent care in SNFs that also serve high proportions of residents with dual eligible status. It will begin with our FY 2027 program year and our FY 2025 performance year, which is right around the corner. It is aligned with the Medicare Shared Savings Program and the Hospital Value-Based Purchasing Program. We considered that it was the best available option we were able to put together with the measures that are available. As I mentioned earlier, the measures in the program themselves are currently not focused on the underserved population. And so you may be wondering, how do you calculate the health equity adjustment in the SNF VBP? I guess it's relatively straightforward, kinda. I was able to wrap my head around it eventually. It's a bonus points based approach in which we take a measure performance scalar and an underserved multiplier. And the measure performance scalar is a binary 0 or 2 score in which SNFs that end up in the top third of performance for each of the 8 measures in the program earn 2 points. That results in there being a potential total of 16 points available if you were in the top third for all 8 measures. The underserved multiplier is the proportion of residents with DES. And for the purposes of the HEA, SNFs must meet a 20% threshold floor to get an HEA bonus payment. We then use a logistic exchange function similar to the one we use for our payment adjustment to generate the number of bonus points that are then added to the sum of all points awarded to the SNFs. Let's see. This slide displays some of the disparities that were existing that we discovered when we were doing our analyses between SNFs serving high proportion residents of the underserved and other SNFs. And don't think I have that much time to go over it, but essentially you can see there that the negative SNF performance score and across each of the individual measures in the program was not ideal, which is why we incorporated the HEA. We ran simulation testing to identify the impact on the proportion of SNFs that receive a net positive incentive payment multiplier for the program. On the left here, it's without the HEA, approximately 19% of overall SNFs would receive a positive payment multiplier, but that number was only 9% for the high dual SNFs. But with the HEA on the right, that number increased to 16% as part of our simulations. Some of the approaches we've considered for our RFI included applying points to health equity adjusted current measures, potential new measures of structural process or outcome-based measures, or a composite measure. And this is all work we're still considering. The RFI was part of last year's final rule or proposed rule. And we've been working on developing and testing measures like our discharge to community measure that are focusing on measuring care to the underserved population and running additional simulations based on the topics that we received comments on, including other proxies for defining the underserved besides dual status, using the underserved measures as performance measures, and applying the underserved measures utilizing additional bonus mechanisms. We've also been exploring the possible application of an HEA-like approach to other VBP programs. Let's see. Here's some health equity emails. And if you have questions about the SNF VBP, you can email our help desk there as well. And I think this is you.
That's me. Hi, everybody. Thanks for sticking with us. My name is Maya Peterson. I'm a nurse by training, and I work for a lot of people at Medicare at CMS. But I'm here to talk to you a little bit about actually our CMMI people laid us out just perfectly for this. Disclaimer, I am not giving you billing advice. The physician fee schedule, just to kind of worry you in Medicare, this is fee for service. This is payment for physicians and other qualified health practitioners. We're going to be talking about care management services, which is kind of a separate carve out of the PFS. If you've ever read it, it's like 1,000 pages long, so have fun. Vocabulary that's important is we're going to be talking about incident to billing, which is kind of part of the care management services. Basically, we pay a practitioner or other qualified health professional, and they pay or have a contract with or a relationship with auxiliary personnel, which is somebody who cannot bill Medicare themselves. I'm going to be talking about principal illness navigation, which we talked about earlier, which is actually came out of the cancer moonshot with the Biden administration. So this is Dr. Jill Biden on her support for PIN. We know these services make an enormous difference in people's lives, which again, we've already heard today. These are the three buckets we're going to be talking about: the SDOH risk assessment, which we also talked about, so I don't really need to be up here, and then community health integration and principal illness navigation. So SDOH risk assessment, this is G0136, for those who are curious. Basically, this is the timed code for the administration of the risk assessment. So 5 to 15 minute timed code. It can be used in conjunction with an evaluation and management visit, pretty wide variety of behavioral health visits. And then again, is the Medicare annual wellness visit. We got a shout out for that earlier. We need more people getting the Medicare annual wellness visit. No cost sharing, part of the annual wellness visit, which is really exciting. Second group is community health integration. So this is in that care management suite, addresses unmet SDOH needs that significantly limit the practitioner's ability to diagnose or treat the patient. As you know, that's the Medicare kind of statute and what we have to meet every time. There's a whole bunch of things that this does. Basically, you have 4 bullets there. It describes the use of auxiliary personnel, including community health workers, to do person-centered planning, navigation, coordination, all of those things. You guys all know how this works, how you get somebody in, so I don't need to tell you that. Principal illness navigation is addressing a serious high-risk condition, illness or disease that's expected to last 3 months, that places the patient at a high risk of major complications, right? Hospitalization, nursing home, acute exacerbation. Again, this is the one that came out of cancer navigation, but we realized that there's a lot of other patients that could benefit for this with a lot of other conditions. We're also really excited to say that this includes substance use disorder and serious mental illness, which we also think are super important parts. The other thing that I'll say is that based on the public comments that we heard, we carved out a separate set of codes for PIN peer support. We heard from the peer support community that we didn't get it quite right when it comes to the activities that they do. So we had listed a whole bunch of things that we needed them to be competent in, and they said we have a really specific role with patients with serious mental illness and substance use disorder. And so they have their own set of PIN codes. Patients with behavioral health conditions can get either, depending on how much of the navigation they need versus how much of the peer support they need. Again, you're familiar with this. You have a concern, you get them into navigation, and then they meet with the navigator. 2 important things, since we've talked so fast. We have an MLN article. So this is the Medicare Learning Network article about the health equity codes. It's also going to include the caregiver training services, which I did not have time to talk about today, but that's another part of our, we're really proud to have gotten that through in the 2024 PFS. And then there is also a CMS FAQ page. Again, as you know from all of us, we take all of your emails and we compiled the most frequently asked questions and tried to give you a good answer there. This is my contact information. I will say, if you want the best, fastest answer, email Medicare physician fee schedule at cms.hhs.gov. If you email me, I will forward it on to them because that's where we'll get all the other experts. Thanks.
Thanks. All right, I'm going to be talking quickly about the Medicare Shared Savings Program advance investment payments. I'm going to do a quick rundown on the Medicare Shared Savings Program to start with, but basically it's a voluntary program that encourages doctors, hospitals, and other healthcare providers to come together as accountable care organization, or ACOs, to give coordinated, high-quality care to their Medicare beneficiaries. Basically, if you're participating in an ACO, the providers continue to bill fee-for-service as normal. And behind the scenes, Medicare looks at historical expenditures for Medicare beneficiaries that see those providers and generate a financial benchmark for those beneficiaries. And then if your group of providers saves money for Medicare, we share some of those savings back with the providers. And these next two slides just go a little bit over the scope of the shared savings program, but we're all across the country. And in 2024, we had 480 ACOs serving 10.8 million beneficiaries. Skip this. But the important thing to know about earning shared savings is important for the advanced investment payments is basically when an ACO joins the shared savings program, they don't actually receive their earned shared savings until about 6 months after the end of their first performance year. So for the first performance year, the first couple of performance years, ACOs need to have their own financial resources to fund that infrastructure. And that's something that can be really challenging for rural or underserved or just smaller organizations in general to put those sorts of financial resources together. And this is where the advanced investment payment come in, because they're essentially flipping that cash flow problem for the ACOs, so it's a new payment option that's nested within the shared savings program that offers ACOs an advancement on their shared saving payment. So it's an upfront payment of $250,000 and then 2 years of quarterly payments to invest in that infrastructure you need to succeed as an ACO. And then for all 5 years of their agreement period, if the ACO is successful in earning shared savings, CMS recoups that money back from the ACO. In terms of payment eligibility, we're focusing on the folks that we think are least likely to have the resources to start up an ACO. So they have to be brand new to the shared savings program, low revenue, and inexperienced with risk. These last two basically mean we want folks to come in at level A of the basic track of the shared savings program, and then we will allow them to continue along the risk track and take on increasing levels of risk as they go through their first 5 years. We just don't want folks to bite off more than they can chew right off the bat. In terms of the amount that we're giving folks, it's pretty generous. It's an upfront fixed payment of $250,000 for everybody, and then quarterly payments that are based on the beneficiary population of the ACO. So it's up to 45, this should say per beneficiary per quarter, but you'll get 45 for every beneficiary who is either dually eligible or is eligible for the low income subsidy, and anybody with an area deprivation index ADI score over 45, and then there's a sliding scale for everybody underneath that based on their area deprivation index that impacts how much money you get. And then there's a cap of 10,000 beneficiaries for folks. So we'll take the 10,000 beneficiaries that earn the most money for your ACO for those quarterly payments. In general, these payments are front-loaded for the ACOs, and then they have all 5 years to spend them. So in 2024, for our first cohort, we'll be giving out $26.1 million, and then they submit a spend plan to us to let us know how they're planning to spend them, and the ACOs are projected to spend $13.4 million in this first year. In terms of what the ACOs are using the money for, there's 3 big categories that they're permitted to use it, which is increased staffing, healthcare infrastructure, and provision of accountable care for underserved beneficiaries. If you look at this chart over here, you can see that the vast majority of the spending right now is being used on increased staffing and healthcare infrastructure, which makes a lot of sense for a brand new ACO. You really need to invest in that infrastructure and the staffing to get everything off the ground to start with. And then in terms of more specific line items, the 3 that are most common for our ACOs are community health workers, electronic quality reporting, and comprehensive health assessments in this first year. And so for 2024, which is our first year of participation, this will be a rolling option for ACOs to join in the shared savings program. We've got 19 participating ACOs, a little over 180,000 beneficiaries assigned to these ACOs, almost 30% that are eligible for Medicaid or the low-income subsidy, 20% with an ADI score over 85, and then more than half that are living in a health provider shortage area or a medically underserved area. And then future participation for folks who are interested in this as an option. This is something that we're going to be accepting a new cohort every year, and our application just opened last week for phase 1 of the program. for phase 1 of our application. So May 20th to June 17th is phase 1, which if you're interested, really strongly recommend that you take a look at that. And then phase 2 is October 18th to October 29th. And the AIP component of the application is nested inside phase 2. So mostly we just ask that folks let us know what they're planning to spend the money on so that we can track and have an understanding of where the money's going. And I think that's it. All right. Thanks so much, everyone.
I'll do this. Whoa, so loud. I'll do this from down here. Thank you all for hanging in with us. You just saw CMS do the fastest work we have ever done. No, this is a testament, though, to the incredible skills of the people that you see here today, both on this panel and everyone here who works at CMS. We are all working in partnership with you. We are trying to keep up with the incredible work you are doing. And everyone is so incredibly committed. So thank you for sticking with us. We look forward to seeing you tomorrow, and go forth.